you're online. Go ahead.
Okay. So I'm Amanda Armagast,
I'm Dr. Abbasi.
I'm John Siegel.
and this is Essence of Life.
Well, we are going to talk today about medical innovation and as well maybe a little talk about the history of medical innovation if time allows us, compare it to other medical innovation because Amanda, you remember one of the things you asked me first when we start working on the marketing for Inspired Spine and OLLIF, you asked me a question. Before you sent actually your grandfather to me.
Yeah, I did send my grandpa actually to see Dr. Abbasi. He ended up not needing the procedure done, but I was wondering, why is OLLIF not the standard of care?
And we have been scratching our head, John, for a long time.
For 5 years at least for me.
For you,
5.5 years.
and even much longer for me. And I think we would like to dissect that matter today on the medical side, on the business side, but as well on the lay person side, to find out if you can do a surgery with 1/30th of the risk of infection, if you can do a surgery with a 1/10 of blood loss, and a surgery that literally put you back on your life within weeks rather than within the months and years, why isn't this becoming standard of care? I think we should start with a little bit of a history. I'm Dr. Abbasi, I'm a neurosurgeon. I'm trained in 3 continents, but I did my residency in Texas. I went through 13 years of residency before I started practicing independently. I did a half residency in Germany, then research in Stanford. I actually wrote algorithm to use the medical technology and computer kind of imaging in the war. In neurosurgery, that is still a big deal, where we instead of make a big opening, we make small opening. And when in 1999, I joined Stanford Image Guidance Lab. We started working on the spine. We created a machine that could use navigation to help the surgeon to do spinal navigation. So I'm inherently into the medical innovation. After that, I did 1 year of residency in Dartmouth Hitchcock College, and then I did additional 8 years of residency in Galveston and Houston, including MD Anderson. And then, so I had a long training. In 2012, somebody told me that they have seen somebody, a surgeon in Atlanta, being able to do a surgery, spinal fusion, under 1 hour and send the patient home same day. And this was exactly my word, bullshit, it's not happening. And I think my blessing was I didn't just say bullshit is not happening, but I said bullshit not happening, I want to see it. And I did go to Atlanta, and a good friend of mine, a good surgeon now, that's still practicing, performed this surgery in 55 minutes. And I watched that patient walking to his car with his family and driving home about 2-3 hours after the surgery. I was an accomplished surgeon by then, but I still could not believe my eyes. And if somebody else would have told me I would have not seen that, I still couldn't believe that. But I saw with my own eyes that patient after a surgery that in my residency would be 7-hour surgery with a half a gallon of blood loss. I saw that patient after 55-minute surgery and after 2 hours observation walking home. At that point, I knew something, I observed something major, something that is going to really change that. I was a little bit of a naive, even though I wasn't a young man. I thought that if anybody who sees that, anybody look at this data has no choice but learn this, and that that a new era in the spine surgery is going to be ushered in.
So why do you think that more people aren't learning this procedure? After your reaction, why do you think other people don't have the same reaction?
Well, no, certainly, one of the first point is many people say, bullshit, I don't believe it, and just walk away. And I think the important thing here is maybe we should turn to John, who has inherited knowledge of the economic of it. Considering the impact of the spine surgery in our lives, in US, our actual, like your grandfather had spine problem. He came to me, he had problem, but he didn't need surgery.
Yeah.
And so in the spine, we are not just about surgery, but this is a common problem. This is a public health issue. John, do you want to introduce yourself first and then tell us a little about how you came to this innovation, and a little about the impact of spine on the U.S. economy and overall U.S. healthcare?
Sure. So my name's John Siegel. I'm the CEO of Inspire Spine. I met Hamid about 6 years ago, started working with him to essentially help him build a product engine to support the demanding growth for these minimally invasive techniques. Okay, during this time, I've learned that right now, the cost of spine-related ailments in this country is about $50 billion per year. Sorry. And with respect to this particular issue, if all of the lumbar fusion surgeries converted to the technique that Dr. Abbasi is speaking about right now, it would deliver a savings of over $3 billion just in perioperative savings alone.
What does that mean, John?
So that just means savings in the time and the costs to treat the patient during the surgery as well as immediately post-op.
Does it include the less risk of infection as well?
Yes.
Okay.
Yes, it does. But what that doesn't include are all of the ancillary impacts of chronic back pain. So people, that continue to have to take opioids. People in terms of lost productivity in the workplace, which that would add, probably another $100 billion.
Yeah, but let's ask actually Amanda a question. I know that your grandfather had some back problem. Did you ever have to take time off and help your family for any ailment general?
Not as much my grandpa as my grandma, but yeah, I do spend one day every week kind of doing things for my grandma, whether it's just stuff around the house, driving her around. But I'm not the only one out of my family. I take one day. Each of my brothers take a day, and my mom takes a day. So that's a lot of man hours for one person.
They really add up in the sense of when the people, especially when they get older, especially people with spine problem, they literally need a lot of help just to live. And that, I think, is one of our main impact. Not only we made a 7-hour surgery, 1-hour surgery, not only we literally made a liter of blood loss to a 50 cc of blood loss and send them home instead of in 7 days, in 1.6 days. I think that's our statistic right now. But as well, we put them back on a path to be independent so much faster, and we have a good track record to showing that we have I have personally taken 1,200 patient testimonial for same reason. And you ask about why people don't jump on the bandwagon. For some people, you have been as well told this is too good to be true.
Absolutely. And from my perspective, from the business angle, with any new product or service or any new type of innovation in any new market, there is always a high degree of skepticism. And that is especially so. It's especially acute in healthcare and most notably so in spine. And that's actually for good reason, okay? Because throughout history, there's been a lot of what we'll call snake oil solutions, as well as some solutions that initially seemed very promising and had initial good results, but the 3, 5, and 7 year results, they ended up failing.
Yeah, I can tell you 30 of them. Yeah, sure.
So there's a natural skepticism, which actually I believe that's healthy. And I consider this to be a rational or productive resistance.
Yeah, and I absolutely agree, and that in special medicine we have to be very skeptical about accepting blindly new things. But I think there is a healthy skepticism and there is a obstructionism that we can see both happening always in any industry.
Well, to your point, Hamid, the obstructionism, as you call it, I have a different name for it. It's called protectionism. All right, so the other key obstacle to the widespread adoption of something that has been demonstrated to be medically superior, both in terms of risk profile and patient outcomes, is quite frankly the power of incumbent interests. Right? Any new disruptive innovation that's going to essentially, threaten them, they're a natural reaction, just like anybody else. I'm not throwing anybody under the bus here, but that's a natural reaction to protect their turf. And again, especially acute in healthcare, most notably spine.
Now, for the people to understand what you are talking about, first of all, by the time you are 50 years old, there's only about 34% chance you don't have spine problem. By the time you're 60 years old, there's only less than 5% risk chance that you don't have spine problem.
So when you say spine problem, is this like a consistent spine problem, or like you throw your back out one time and then you go to the chiropractor?
A combination, but by the time you're 70 years old, that chance is less than 1 to 2% that you don't have spine problem. So this is a very common problem that all of us have to deal in our life. A certain percentage of those people need a surgery. And a certain percentage of those people need a kind of surgery that the disc, I compare it to my patient like a tire of a car. It wears and tears, and eventually that tire is not usable. In a situation like that, we take the tire out and put something inside to lift the bone, and then we stabilize the spine with hardware. This is a complex surgery, but it has been refined over the last 20 years. Now, the problem with our spine is that our spine is in the middle of our body. And what that means for a surgeon, you have to get in. And there are ways to get in. Either we cut open your belly. By the way, I have done all these surgeries. I would be called an expert in all these surgeries. You cut open your belly, you push the bowel and the organs to the side, major vessels to the side. You go from the front. When you go from the back, we not figuratively, we literally fill you open. We cut all the muscles of the spine. And guess what? The amount of the damage we do sometimes offsets the benefit of the surgery. Now, the surgery that I'm describing, we get to the spine to a tube that is barely thicker than this pen. Now, so I did 3 of those surgeries today. 2 of those patients came from, one came from Idaho, one came from West Virginia to get the surgery done here today in Minneapolis. So, this is a common problem. These patients are being told, no, you're too sick, you're too old, you have to live with the pain. And they don't live with the pain. Most of them, they decondition and die with the pain. And considering those surgeries that are done already in the United States, Amanda, you did a research. How many surgeries, spine surgeries were done in the United States last year?
About 1.6 million surgeries are done, but that's only surgeries that are done because a lot of doctors sometimes turn patients away for.
And they come to us.
Well, and to that point, the reason why they turn them away isn't because they don't care about them. It's just that the risk profile of the technique for the surgery that those patients need after those patients fail their conservative measures is too risky.
Yeah, it's just not justified.
They're essentially the mortality rates are too high. So those doctors are actually doing their job.
They're doing their
Right.
job. Now, they're doing their job to a point, but if you confront or you tell that surgeon, there is another way to help this surgeon, like I'm a neurosurgeon. If somebody comes with a cardiac problem to me, I say go to a cardiologist. As well, I'm not a pediatric spine surgeon. If a child comes to me with a pediatric problem, I send that patient to Dr. Kim, who's a fantastic pediatric scoliosis surgeon. I cannot wash my discipline of any kind of. I cannot give them a free pass here because we should know better. Many times when we confront them with the data, the reaction is not, show me the data. The reaction is not happy. It's not true.
I don't have time to review your data.
I do not have time to review the data.
And you see that all the time.
Even in universities, I see that all the time. I think this is a betrayal of the public trust if you are confronted with the data that could benefit the patient, and then you decide not even look over the data for whatever reason.
Well, to your point, I think we need to go back to my earlier point about incumbent interests. Okay, so many of these spine surgeons are, paid legally and above board are paid millions of dollars per year by large device companies. Okay, so even though show them, for things that, for products where they have royalties and where they do consulting, so it's all above board, it's all legal. Okay, but even though you can show them from a scientific medical standpoint, this is not only better for your patient, but it's also better for you in terms of your time and your outcomes. In the back of their mind, they don't want to sacrifice those $3 million checks every year.
Yeah, and I think a certain point as well here, what we are talking about is that obviously what we do is extremely technical. It is extremely technical. Like imagine cutting somebody's skull, taking a tumor out, putting him back together, and he lives. This is, or the spine, the anatomy of the spine is even more complex. Being able to be like today, I put many screws in a structure that is called pedicle. It's about 7.5 millimeter. I put 7.5 millimeter screw in a 7.5 millimeter pedicle, and I did over and over that again. Without one side, I would be in the patient's aorta, patient would bleed out. At the other side, the screw would be in spinal cord, and patient would be paralyzed. The amount of the knowledge and technology and expertise goes to this is nothing short of going to the moon and back. But this is acquired over years. Once we are done with our residency, where we acquire this knowledge, we get so busy. Coming back to your question, why not many more people are doing that? We are human as well. We want to enjoy our life.
Yeah.
We don't want to be in the perpetual kind of training, all this, except if you have no other hobbies like me, then exactly that's what you do.
Well, I'm almost afraid to hear you say that about doctors don't want to keep learning.
Yeah.
Right.
Because as we
Yeah.
know, science by definition is continually evolving as we gain more knowledge. It's about hypotheses, test, yes or no, and then reiterate. So the fact that you just mentioned that most surgeons don't want to stay up, continue learning, it's kind of a scary thought.
It really is.
It is, but what saves us is they have a certain period and they die out, and the new generation always learns new things. And this phrase is not from me. This phrase is from Max Planck, the German theoretical physicist who invented quantum physics. By the way, this cell phone, the way you look at us and able to hear us is based on all the knowledge we gained from the quantum physics. That's how the chip works. We couldn't build these chips.
Our society right now is completely dependent upon that technology.
When this came out, by Max Planck started that thing, this was just too crazy for everybody. And he was laughed off. He was not taken serious. And there's a phrase from him, he said that science improves one funeral at a time. Because what we are doing, it is sometimes not evidence-based medicine, it's eminent-based medicine, meaning that few people in eminent position, chair of a thing, people do what they say. Really, it doesn't matter if there's any evidence for that or not. And that is, I think, I'm sad to see that 120 years after Max Planck, that we're still dealing with this eminent kind of science, that the eminent person on their way have to die before the new things is ushered in science or medicine.
So it's almost a corollary to the concept of creative destruction that's coined in business.
Yeah.
Whereas, with these innovations, the old way of doing business, people are so married to it, and it's the way that they've always done it. They've built a whole infrastructure to support it. It takes a lot to move them off that dime in order to embrace something new, which ultimately 3-5 years down the road will be substantially better and more effective.
Now, the part that is personal to me is while we are going through this natural process on innovation and accepting the innovation, there are patients today gathering their pills to commit suicide because they are told by their surgeon they have to live with it. They are told we have a problem, we have to live with it. And it is sometimes hard to be old, but it's much harder to be old and in horrible pain and dependent on everybody else. And the numbers are probably much higher than we want to have. Number of the people that they don't decide, they don't want to live with that, whereas we have a solution for them. And that as well, that is very personal to me because I have been by many of my patients. If that's all what's left, I choose not to live.
And think about that sampling size. Okay, so how many patients do you treat per year?
I treat probably over 1,000 patients a year, but I probably perform on a fraction of them surgery.
Correct.
Probably many thousands, and probably a small fraction of them get surgery.
So, but a substantial of them that do get, or a substantial number of them that do get surgery are in continuous dire pain, and many of them have been told you're not qualified for the particular surgery that you need because of your risk profile. And then if you extrapolate that across the country, it's probably hundreds of thousands or even millions of people that are basically destined or required to live out their remaining years in dire pain.
Right.
I think one of the problem in medicine as well is that the true beneficiary of the medicine are the patient, the public. But the delivery is not like any other service. Like, if I go and buy this, I go to a store, Apple produces this, I go to a store, I buy it, I pay for it. Now,
and it's your decision too
Yeah.
to go and buy it where you're going is insurance.
Yes, but look at that. Imagine now, John, try to this model. Apple produce it. There is a store. I go to the store. I buy it and I pay for it. Try to fit medicine in this concept.
Or just absolutely. Because right now, especially for specialty medicine, because the actual customer is dependent upon what is known as a learned intermediary or the doctor to tell them which products they need.
Yeah.
Completely.
Now imagine that this is produced by Apple, but the Apple has to go and sell it to the store, and then I go to a second store, and that second store send me to the store they choose to get all of them, and on top of that, I'm not paying for it. Somebody else, an insurance, is paying for this. It's so convoluted that the benefits to the true beneficiary, it doesn't really calculate the way a regular service would.
Correct.
And for that reason, I think we decided about a few years ago that that is what this is about, to go to the public. We need to make the public knowledgeable about their choices. And sometimes when I put this, my result and so on online, and many of my colleagues are very critical that I'm so open about that I put patient testimonial and so on and so forth, and my results out there for the public. But the way I see that with the internet, like what we are doing right now, the public has never been more knowledgeable than today. They know their choices and they are aware, like those two patients that I did the surgery today, they got the information from online.
Yeah.
And one of them actually has read all our papers because I chose to put our papers for a public domain that anybody can read, that rather than in a journal that you have to pay $150 to be able to get a copy of the paper.
Absolutely, and with that knowledge comes power. So 20, 30 years, even 10 or 15 years ago, the patient, for lack of a better word, was at the mercy of their primary care provider or their specialist to say, yes, here's what you need. Right? Now that that patient has much more education, much more knowledge, they are in a much more powerful position to have a much larger say in their healthcare.
Right.
So, Amanda, you helped me a lot to put many of this information disseminate through the internet sphere. We don't want to mention any names, but we have few friends all across the world.
Frenemies.
Feminists, yeah. So, what? Now, I want to go both ways. What are the things that you hear, or what do they say? Now our colleagues. I'm talking about the spine surgeon. That how they react when I tell them I did 3 surgeries today. Each of the surgery 2-level fusion. Each of the surgeries was actually 50 minutes, 50 minutes, 52 minutes. Our blood loss was less than half a cup of coffee, and all these patients are going home tomorrow, most likely within 24 hours, because we have statistic of that. I put this information out there. What are a few things you hear out?
I can think of 2 or 3 main things that I hear a lot. Obviously, one of them is, what about their lordosis?
Yeah.
That's a big one. Another one is speed isn't the most important thing. So do you want to talk about that a little bit?
Absolutely, yeah. It's never about the speed, it's about the efficiency. And I tell that as well to many of my colleagues, that it's not like I make a 7-hour surgeries in 50 minutes. This is a different kind of surgery that we're performing. This is like, I tell patients, we are in Minneapolis, how long would you need to drive to Chicago from here?
8 hours.
So yeah, somewhere between 8 hours. Imagine if you have a very good car, very good road, you could drive there maybe 6 hours, maybe 5.5 hours, then you're pushing it.
Yep.
Anything beyond that, I would say, if I had no idea what flying is, if driving was the only concept of transportation I knew, I would say, and you would come and tell me you got from here to Chicago in 1.5 hours, something's wrong with you.
Right.
Either you are very reckless, you're lying, and so on. But if it takes you 7 hours from here to fly to Chicago, as well is something wrong with you.
Yeah.
Because that is a different mode of transportation that should not take that long. Now, as well, the concept of what's possible and not possible has been well described in the economy and in the game theory. You know what I'm going to refer to? The Kobayashi effect.
Yep.
Now,
The hot dogs.
yeah, tell us tell us about the Kobayashi. What do you know about the hot dog guy?
All that I know is Kobayashi is the famous guy each year at the Nathan's Hot Dog Eating Contest in Coney Island. He's the one who wins every year, and he's this little skinny. I think he's Japanese.
Yeah.
Correct.
So the idea was that don't do that at home. Don't go and do hot dog eating contest, but it's not healthy. But it has been going on for many decades.
Correct.
This hot dog concept. How many hot dogs can you eat in 11 minutes? I don't know why it's 11 minutes. But the record was somewhere between 25 and 30 for years, for decades. It was just moved from 25 to 28 to 30. All of a sudden, this thin, skinny Japanese guy comes and he needs money. He goes and eats 6 dogs.
Is he the one who's like dipping them in water?
Yes, that is the idea. See, everybody until then thought the inside of the box. How many hot dogs can I eat in 11 minutes? This guy made a science of it, took it apart, and found out how he can improve each dog. Like, he literally, nothing in the rules get that you have to eat the hot dog as a whole. So he took the buns, put it in water, out, and put it in mouth, and then he actually swallowed the hot dogs as a whole. He made a science of it, completely changed the concept. And now all of a sudden, he went from 30 to 60, that people know they can do it in a different way. Until then, this is all what you can do. But once they know you can do it differently, now everybody does it. And that is another thing that people think this is Abbasi's superior technique. It is not. It's a different mode of surgery that enables. You have to learn it, obviously, and I have the highest reported number. But once you learn that, this is a learnable technique, and we have a proof of that. You tell us about that.
So what's interesting, of the surgeons that we've trained, and I'm going to give the example of Dr. Sonny Kim, who is a veteran surgeon, tens of thousands of cases. He's been practicing for over 30 years. Okay, and he was known for doing big spine surgeries, as Hamid alluded to earlier. He has expertise in pediatric scoliosis. Okay, so with respect to Hamid, it took him about 500 cases to be able to do complex pathologies. Okay, with Hamid training Sonny and identifying for him prior to Sonny having to stumble upon it on his own, all of the potential obstacles that you can run into with this technique. Sonny achieved, or basically got to, a level of the same proficiency that took Hamid 500 cases in about 150 cases.
And that is, I think that's the nature of any kind of teaching. The first person learns it based on
The hard
small
way.
hardware, a small increment, and then all the others don't have to do the same kind of hard way. They'll learn it easier because they can replicate. Like literally, it took me 180 cases until we ended up with the draping system that we are using today. Because I tried 7 to 9 different draping methods. It took us about 200 cases to just identify in this crowded room or what is the optimum position of the big instrument like C-arm or and so on and so forth. Now, they don't have to do that. They just go to replicate. The knowledge is transferable very easily.
Well, and I think one thing that you might want to make note of, Hamid, is the fact that when we tell people or we show them that instead of taking 4 hours, the actual what's called skin-to-skin time was 47 minutes. Again, it's not because the surgeon is rushing through anything. There's a dichotomy between access time and treatment time. And the reason why the traditional techniques, they have an access time of over an hour, and sometimes, in some cases, depending upon the size of the patient, so to speak, several hours. Okay, and then once they reach the pathology, they're able to treat it the same way we do. Our access time, or the access time of the OLLIF technique, is about what, 87 seconds?
Yeah, well,
Typically?
Minutes, yeah.
Why is that? What causes the huge difference?
In an open surgery, traditional surgery, first of all, you cut in the middle. What's going to happen? Patient's going to bleed. You literally, with electricity, cook the tissue to stop the bleeding. By the way, that creates a lot of dead tissue and it's ready to get infected. That is why open surgery has a 3 to 5% risk of infection, and we have at this point 0.17.
You're creating an open wound.
Yeah, and then once you stop the bleeding, you go to the next layer and you repeat that again and again. You cut, you cook the tissue, and then once you are there, you cut especially a big part of the bone in the spine, and guess what? The spine is already weak, and you cut more of it and make it weaker until you get to the disc. Once you get to the disc, that is where the whole problem starts, because our spinal cord is surrounded by a plexus of veins. They call them epidural venous plexus. That's the fitting. You touch them, they bleed. And we spend a lot of time to stop that bleeding to get access to the disc. As a matter of fact, more than half of the blood loss, during the spine surgery is when you get to that plexus, you're trying to stop that bleeding to get inside of the disc. Now, that makes sense, that it takes a long time, create lots of dead tissue, and that makes sense as well that if you have to go deeper, it takes longer, and we have data about that. We know that if the BMI, as a matter of fact, many of our societies say that if the BMI is over 40, body mass index, don't do surgery. We easily doing this surgery on people on BMI of 50 and above successfully. Send them home next day. We have data showing them that the BMI doesn't really impact their outcome. No more risk of infection, no more morbidity, mortality, and so on and so forth. We made a chart of it. And this is for me personal. When I show that to my colleagues, that their curiosity doesn't go to Mount Everest, that they don't come back and ask me, I want to see the raw data. If this is true, and we gather, as you know, both of you know, I'm very obsessive compulsive about my data, that the amount of the data we are collecting is tremendous. And I offer all of them to come and look at the raw data, and some of them, all they care about is view, comment, and linking.
Yeah, they're Twitter. It's called Twitter fingers.
Twitter fingers, yeah. They are very active on the social media, but they don't spend the same amount of time to actually look over the data.
Well, and what's interesting about that, because I've seen those comments,
Yeah.
right? And I've
But
heard,
which one have you seen?
I've heard a ton of, I've heard basically 8 key objections.
Tell us someone. Let's go.
But one of the first one is always, for a minimally invasive technique where I'm not opening up the patient, the risk of nerve root damage is much higher
Okay, let's go over that.
than with open surgery. And it's because I can't see that nerve root on that fluoroscopic image.
Well, let me use another analogy from the aviation. There's so-called VFR, visual flight rule. There is a so-called IFR, instrument flight rule. In the visual flight rule, like open surgery, you open it up, you look at it. There are certain routes, and like most of the airplanes that are flying commercially, they are not visual flight rule. They are instrument flight rule. What we do is mostly instrument flight rule. We have a machine, a computer checking your nerves, and I'm going with a probe close to that, and then it gives me signal. Now, visual flight rule is like flying a small plane in a daylight and so on. And the instrument flight rule is flying from here to Germany. Which one is safer? Everybody knows that the visual flight rule are never as accurate as instrument flight rule. Same way here. We have enough data to show by us using probe and computer that check the nerves while they're in life. And as well, in our surgery, we have 2 X-rays that shows the tip of our instrument in every level. After having done this now for over 1,500 cases, 3,300 levels, and for the last 10 years, I think we have enough data to show, just open up the books, show the raw data. There's no comparison. In our study, only one patient in 303 patients after a year still had nerve injury. That risk is reported from ours is 0.3.
0.3%, correct.
In the open traditional surgery, that has been reported lowest in a very limited group has been reported from 0.3 to 35%. This has been reported and generally is accepted for 3 to about 1 to 4 or 2 to 3%. So that risk is a fraction of open surgery.
So I've got to ask you a question. So why is it that, a certain percentage of OLLIF patients, immediate post-op, complain of nerve root irritation versus patients that undergo what's known as a TLIF or a transforaminal open, they're not complaining of nerve root irritation post-op, immediate post-op. Why is that?
That is a very good question, and we systematically looked into that. You have to see an OLLIF patient and a traditional surgery patient post-op day 1 to really understand what you're dealing with. Like, imagine if you go to your grandmother and your grandmother is on fire, she's not going to complain about the hair, that the hair color didn't came out right. This patient after open surgery, they're on fire. They're happy if they can turn from side to side. The numbness on the top of their left foot or that they cannot bring their foot. That's the least problem. They just want this horrible pain to stop. Whereas my patient, I have thousand testimonials. Many of them just the day after the surgery, they're looking at you, they're smiling, you're ready to go home. Now, if you're not on fire, the color of your
Yeah, you're going to pay
hairdresser.
attention to other things.
that
So
comes
it's a
up.
hierarchy of discomfort, shall we
Yeah.
say?
Yes. Now, practically, what we methodically looked into that rate, that initial, and in all the papers we look at, they just put it on the table. They go to long-term data. They are very vague about, but we methodically looked at that early, middle, long. It was 12% for immediate post-surgery. For open traditional surgery, it was 8.2 in our. Even that is lower. But our patients are ready to go home. They have packed their stuff, and they just want to know why is the top of the foot not-
Wet.
Yeah.
It feels wet inside.
Yeah, but that has a fantastic prognosis. We know that even for open surgeries has a relatively good prognosis. But even looking at that was lower in our study, and we have enough data to collaborate on that. The fact is that we don't have a single. I don't have a single take back to surgery for infection, and if you see one spinal infection, you know how tremendously detrimental that is. Or you know that this is the public data. What did you find out, John, about the hospital stay in the state of Minnesota?
So the average hospital stay for traditional lumbar fusion surgeries ranges anywhere from about 3.2 to 8 days post-op. Okay? For OLLIF, my understanding is, and this has been very, very consistent and published data by the Minnesota Hospital Association, is 1.6 days.
How can you say that? How do you know that's 1.6 days?
Well, because there's one hospital where Inspired Spine, they are the spine surgery service.
Yeah, you're the
So-
only spine
So
surgeon.
they are the only game in town, basically. It's Riverview Health up in Crookston, Minnesota. And when you look up Riverview Health under DRG 455, which is for anterior posterior lumbar fusion, the average length of stay is 1.6 days.
Whereas that number for some of the hospitals here in the town is 7%, 7 days, right?
Correct. And what's very interesting too, the hospitals where we also bring patients in the cities, when you include our surgeries, their average length of stay is about 2.4 days. When you tease out, so to speak, our surgeries from that data, the average length of stay is 4.2 days.
So we practically bring the average hospital stay for the hospital 1.5 day or 1.7 days.
We basically cut it by a factor of 2, the way Kobayashi
Yeah.
increased by a factor of 2. Factor of 2.
So they must love you, John. Do they?
The hospitals here?
Yeah.
Me personally, no. In terms of, well, what's very interesting, so due to the fact that we are getting the word out, we've been generating patient demand, 130 new patients per month on average for the last 2 years. Okay, so we have a very large backlog of surgeries that we need a venue for. So on several occasions, we've gone to a particularly large system where Dr. Abbasi and Dr. Kim currently have privileges, and we've asked them for more OR block time.
Well, how was the
Okay.
reception?
Well, it was interesting due to the fact that one of the key factors for not giving us that block time was what they told us was they have contracts with a large medical device manufacturer that at the end of the year, the hospital needs to meet certain volume limits on their implant purchases from that particular manufacturer in order to get their rebate. So they were concerned that by giving us more block time, the OLLIF surgery, which can't use those particular implants because for obvious reasons, this particular technique requires specialized instrumentation, the OLLIF surgery would essentially have too large a percentage of their OR time, which would result in them not purchasing a sufficient amount of these devices from this large device company, and they don't get their rebate.
So I, quite frankly asked, I said, so you mean to tell me that this particular company sets your OR scheduling policies? And I heard no comment. So.
And considering that, we can do 6 of those surgeries in one day and increase the efficiency of the hospital.
And the patient's
especially
going home in a
COVID
day and a
time.
half.
And the patient don't stay there.
Well, and not to mention, like, those procedures I'm sure take much longer than OLLIF, so
Yeah.
it's one patient versus 2 or
Many
3.
patients.
We can do 6 in the time it takes them to do 2. In fact, Hamid's home for dinner after
Yeah.
he's done 6.
But I think that may not come out how important that is, except when you have gone through the COVID, how limited the resources of the hospital were. If you can make the patient stay in the hospital where every bed is valuable, 1.6 days versus 7 days. If you can use that highly skilled people in 1 hour, like today, all my surgeries were under 1 hour, skin to skin, for 2-level fusion. We have good data. That is average 3-4 hour surgery.
And you stopped by my office at 2:30 this afternoon.
Yeah. Well, that was after I went and checked on all my patients.
That's my point.
And then
Yeah.
I did all my dictation and so on. That was long after I did all the other work. Considering the impact this can have, that is, for me, just not understandable how hospitals, some hospitals, but how any hospital wouldn't, literally want to be your best buddy, John.
Well,
What do you think going on?
What's confusing me comes down to, I'm going to sound a little, skeptical and whatever. But what's interesting, so there's 2 basic concepts here. There's patient outcomes, best interest of patient, and then there's financial. All right, and in many cases, as people have heard or they hear every day, one is typically sacrificed for the other. Okay, the beauty of what we deliver is there's no trade-off. We're optimizing both. Not only are our patient outcomes better, but the financial performance of these surgeries for these facilities is better by a factor of 5 or 6x.
I'm going to almost sound like a conspiracy theorist right now, but it might be some how do you call those thing that in like Da Vinci Code, that what they call this special
Legal lobbyists?
No.
So almost
Like these cults or like these special.
It's not. It almost sounds like it's a cultish thing around. Holding you back because it is good for the patient, it is bottom line good for the hospital. And today, 2 patients flew all across the United States to go to
Correct.
this hospital.
And essentially, so I want
Three
to
patients.
add to that point. It's not as though our practice is relying on this healthcare system to bring us patients.
No.
We're bringing them patients,
Yeah.
and still the red carpet is not effectively rolled out. Which and what's interesting to contrast that, we're treated like kings up in rural Minnesota, where we have a professional services agreement with the hospital that I mentioned before, called Riverview Health in Crookston. Crookston, for those of you that do not know, is an hour north of Fargo on the Minnesota-North Dakota border.
And we are providing, people are coming from the entire United States to Crookston, Minnesota to get their spine care.
It's a center of excellence where the post-op length of stay for what has been traditionally a high acuity lumbar fusion surgery is 1.6 days.
Shorter than any university, any bigger system, in the center of medical expertise, which is
Minnesota.
Well,
Minnesota.
and 1 hour away from Mayo Clinic,
Yeah.
even.
Yeah.
Which
Correct.
Yeah.
I wasn't going to mention that, but I was
Oh.
going to say that it rhymes with KO.
I have almost in the last 12 months, I had like 24 patients coming from around the Mayo Clinic from Rochester to Crookston, Minnesota to get their care.
I know. And in fact, I remember 3 particular patients, elderly women, that had adult degenerative scoliosis. They were told by the surgeon at the Mayo Clinic that the surgery they required would have to be done over 2 days. That he would have to basically cut them from what's called your occipital, so the base of your skull, to your sacrum, so that he could straighten them out. Okay, we were able to, well, I'll let Hamid explain it, but we were able to effectively treat all three of those patients with surgeries that were less than 2 hours.
And send them home within 2 days. And that is something consistently we have been. I think the problem or maybe the blessing of Crookston is it's a community. Everybody in the community knows everybody. So when they say they are there for the care of the community, it is not empty word.
They actually care.
They actually care. Because however you look at it, you cannot care for patient care, have the data, because many hospitals, they have the actual data that we are treating for years patient there. You cannot say you are for the care of patient, have the actual data and not roll out the red carpet for you to even create more care there. The only thing I can explain here is that there's a schizophrenic dissociation between the motto, we are for care of patient, to execution of providing that care. And on top of that as well, the financial, at the end of the day, OLLIF is not more expensive than traditional surgery.
The devices required for it are no.
No,
No, it's the same cost.
Same cost, contrary to some other technology that the iPhone 14 is cost your,
1,500 right
cost your arm and leg
Correct.
and your firstborn son. No.
now. You go and buy it cash even.
Well,
That's
and the hospitals are being paid the same amount for the OLLIF surgery as they are for a big open surgery.
Yeah. So, and considering those patients go home sooner, so meaning that is actually beneficial for the hospital. But there is a dissociation between putting all these results and the premise that we are here for patients' care to actual use.
So what are some of the other OLLIF objections that you guys see?
Like, let me talk about the lordosis. That,
Yeah. What about
technicality? That
Yeah.
I would actually talk about that the special insurance that they have their own surgeons. We provided to them information about how less our patient get infected. We provided to them information about, and we wanted them, even train their surgeon for them. Obviously, they go to their surgeon. Their surgeons are in their 60s and 70s. They have no interest to go back to school and learn. Now, and we provided them actual data. Now, John, what did they come back to you with? What did they ask you? Did they ask you how you can help them, or
when's the training?
No, they
When's the
basically,
training?
so their response to us after we presented all of our data and explained our outcomes and compared them to the outcomes of the surgeons that were in their current network or that work at their hospitals, they basically came back and called our procedure experimental.
but they reversed that?
And yes. So after demonstrating to them the actual data, as well as sending it to their C-suite, about 2 weeks later they came back and they reversed that.
Actually,
But then they gave you a different reason, didn't they? Like, didn't they keep saying like, oh, actually it's this, now it's this? Like,
yeah, they tried to use a technicality, a code in the how these are coded to say that this surgery doesn't qualify. Now, imagine that you have a heart defibrillator that's going to go and save somebody's life, but then the code says, it should be red.
and I had
And
it
yours is blue.
Yeah.
Yours is blue, and you save people's life. They say, no, this is not red. You cannot save people's life because this is blue, which has truly nothing to do with what you are trying to do.
Well, I'm sorry, Hamid, but what they were focused on is what I deem to be prescriptive requirements, procedural aspects versus substantive or performance aspects. And I think what got them was the fact that I pointed out that why would they be requiring their membership, their covered lives, to receive a surgery that on average at their hospital has a post-op length of stay of 6.2 days versus one that has a post-op length of stay of 1.6 days.
Yeah. So, if you are working for a health partner, we are talking about you. Okay? You're not doing a service to your member, and you are being dishonest if you tell your patient you are there to give them the best care, but then when we show you what we can do for your patient, based on that you have your own hospital, you have your own surgeon, you literally exclude us from your network, so your patient has to pay a lot more to come to get care from us, or have to do a surgery that has 30 times more risk of infection.
And these are only the patients that the surgeon will operate on.
Yes.
Not the ones with the high BMI, elderly, too young.
Yeah.
Which, to mention the BMI thing again, I read actually that Dwayne "The Rock" Johnson is technically obese because of his height
Yeah.
to weight ratio. So you're gonna like these
Is that
doctors.
Rock? Is that
Yeah.
the Rock?
These
All
doctors would.
professional athletes are technically obese.
Yeah, so these doctors would turn away these professional athletes.
No, I think they are a little more. I think most of surgeons are a little more judicious about.
Yeah.
Do you think?
It
Because-
depends whether the BMI is from based on muscle versus fat.
Right, but when you look on your LinkedIn comments, they always say, I would never do surgery on a patient with that BMI.
Yeah.
But they don't.
And as well, what really was hurtful that some of them even tried to body shame the
Yeah.
patient. You know, obesity is a disease.
And these are American surgeons.
They
So
should know
they look outside.
Yeah, they should know better that, you know.
Tell them to lose 100 pounds or they can't get the surgery.
What about 250
Yeah.
pounds?
Yeah.
And or you know, and the thing is, they should take responsibility. How are you going to walk and lose
You're in
weight if you
agonizing
cannot-
pain.
if you cannot
Exactly.
walk?
Exactly.
Oh, water aerobics, that's what they always
No,
say.
what I don't understand, we are supposed to be empathic. We are supposed to, you know, be able to have empathy for our patient, rather than say you deserve to be in pain because you just let yourself go and now you are 350 pounds. That is unbecoming of our profession to do that. And yet, no, we have few minutes time. I want to finish it up on time at 5 o'clock. But few other comments that lordosis, that we can correct that. We can put the cage in the front and back. That's not the question. But they just repeat the same question. They don't listen to the answer.
Correct.
So what, each time, what other objection do you hear?
I cannot get a sufficient enough discectomy.
Plate preparation through that 8 millimeter diameter tube.
Come to us and we show it to you. It is not only possible, the surgeon who performed that, they use this instrumentation, we put a tube in, and we can go 60 times inside and outside of the tube without putting spinal cord as a danger. There's a word called durotomy, meaning that inadvertently, accidentally, we nick the skin around the spinal cord and let them they will lose CSF, cerebrospinal fluid. It's a mess. That rate of open surgery is 8.7%. What is our rate of?
So to date, 0% after almost 1,700 cases. I'm just gonna
So you go ahead with some other objection.
We touched on this a little bit, but the fact that you post onto Curious versus the paid for
Good
Spine
one.
Journal.
Because my patient are able to go to Curious, get that paper, and just read it, and you will be surprised. They are smarter than ever. There's Google. They can look up the phrases. They can take it, print it out, talk to their family, friends, or their physical therapist friends, or family doctor, and so on. And rather than in a professional journal, you either pay about $150 per article, or you pay about $3,000 to get a subscription.
One last one that I want to bring up because it's one that I hear quite often, and it's the focus of the reps of the other device companies have trained these doctors in terms of looking at, when they look at alternative devices to be used for this fusion technique. One of the things they bring up, they say, well, the footprint or the area of that, what's called a cage or a spacer, is too small. I'm concerned that I'll get way too much what's called subsidence. Would you speak to that?
Well,
Wait, what is subsidence?
meaning that that spacer that we put in, it's smaller comparing to some of the spacers that go from the front or side, because most of the devices that go from the back, they have the same footprint. The idea is here that if you put something bigger, that there's more space contact and there's less overall force on it, and it doesn't sink into the bone. I love that movie with Tom Cruise. Show me the cash.
Show me the money.
Show me the money.
Jerry Maguire.
Jerry Maguire. Practically, I apologize. Can you answer that? Tell them I will be there in a minute. It's I apologize. I'm always on call. So, show me the result. What is the result? Patient outcome. And I'm happy to compare the patient outcome to any of those cases with a bigger footprint. They have no advantage except those surgeries are much longer and have more risk of infection. It seems that our body, and we have been doing this with the same footprint, these cages from the back, for 20 years before we start doing it from other places. Is that your? Okay. Now, it is 5 o'clock right now, and I have a call from the ER I have to answer. So I'm going to conclude this. I'm Dr. Abbasi with IS Life. This is our Essence of Medicine.
I'm Amanda Armagas. Thanks for joining us.
Thank you very much.
Okay, thank you. We can start this.
That was really good, guys.
Yeah.
John, you have a really nice voice for.
Yeah.
Yeah, it's like a radio
Hello?
voice.
Oh, what did they say?
I told them that you will be available in 5 minutes.